Hello, thank you for joining us today for our virtual Healthy Minds, Healthy Bodies seminar. Today's topic is about signs and symptoms of a stroke and what to do if you think you or a loved one is experiencing a stroke. A link to a survey will be provided at the end within the Q&A box, so you may give us your feedback regarding today's presentation. You will also receive an additional link for a survey to test your knowledge about today's presentation. Our presenter today is Jodie Andrews, Stroke Coordinator at Samaritan Albany General Hospital. Stroke Coordinators Sarah Vincent and Dan Sherman from Good Samaritan Regional Medical Center are also joining us behind the scenes to help facilitate the Q&A portion of the event. So welcome, Jodie, Sarah, and Dan. I will now hand it over to you.
Wonderful. Thank you so much, Erin. We are so happy to be here, and thank you to everyone for tuning in and joining us to learn a bit more about strokes, what they are, and the signs and symptoms. So welcome to our Save Time, Save Brain presentation. First, I want to give a little bit of a background onto Samaritan Health Services stroke programs. We have two primary stroke centers within our 5-hospital network. These two are Good Samaritan Regional Medical Center in Corvallis and Samaritan Albany General Hospital here in Albany. The other 3 Samaritan sites, Samaritan Lebanon Community Hospital, Samaritan Pacific Community Hospital, and Samaritan North Lincoln Hospital, are all critical access hospitals. What this means is the primary stroke centers are accredited through our accrediting body, DNB. We are equipped to handle strokes at any point with 24-hour imaging and specially trained staff to admit those patients who may need medication treatment for a stroke and some more intervention. The critical access hospitals are equipped in their emergency room to triage and emergently treat those patients and then send them to a primary stroke center for further workup and admission. What we cannot do at a primary stroke center is that surgical intervention for stroke. That patient would have to go to a critical access hospital or a comprehensive stroke center, and we do not have one in our network. However, our primary stroke centers are more than capable to triage and treat that patient emergently before having to transfer. So stroke background, why should we care about strokes? They're a huge deal, and I'm sure you already know that, but in the United States, every 40 seconds, somebody has a stroke, and every 4 minutes, somebody dies from a stroke. Stroke is the leading cause of long-term disability, and it is the 5th leading cause of death. It's been really incredible in the last few years. We have seen stroke go from the 4th leading cause of death to the 5th, which is awesome improvement in our medical approach to treating strokes. However, still that long-term disability leading cause, and that's really, as a stroke program, that's our end goal, is to hopefully reduce that long-term disability in each of our patients. So what is a stroke? Simply put, a stroke is a brain attack. That same mechanism in a heart attack is what's happening in the brain, so just a different location. It's a sudden death of brain cells caused by either a blockage, so a blood clot, or a bleed. Blood is fantastic, we need it to survive. However, blood coming out of those vessels in the brain is toxic to brain cells. There are 2 types of strokes. There is ischemic, which is the most common, and that is the blood clot in the brain. That can either form directly in that blood vessel in the brain or form somewhere else in the body and travel to the brain, similar to a pulmonary embolism or a heart attack. And then there's the hemorrhagic, the less common type of stroke, and that is a bleed in the brain. Often you will hear somebody say they have had a mini stroke, and that is generally referring to a transient ischemic attack, or a TIA. Mini stroke is really a misnomer. It's not accurate. A TIA is not a true stroke. It's really a warning sign that maybe a stroke could be coming. There might be something going on in that patient's body that's causing a brief symptom like a stroke. It's kind of a brief change in blood flow to part of the brain that gives those same symptoms as a stroke. However, they are temporary and they resolve. So it's a great thing to come in and get checked on with those stroke symptoms and find out if there's more going on in the background that's causing those TIAs and hopefully prevent a big stroke from ever happening. Before we get into how to identify a stroke, let's talk a bit about risk factors. You will notice on this list that age is not listed, and that is on purpose. We get asked as stroke coordinators a lot if age is a big risk factor for stroke. And in a sense, it can be, but it's because once you're over really the age of 50, that patient population is more inclined to have one or multiple of these other risk factors listed here. But somebody can have a stroke at any age. On this list, we have high blood pressure, diabetes, atrial fibrillation, obesity, high cholesterol, smoking, which is a big one, sedentary lifestyle, so that not being very active, and a personal or family history of stroke. Unfortunately, if you've had one stroke in your life, you are at a higher risk to have further strokes. Prevention really goes back to that list of what are your risk factors. If you smoke, it's time to quit. It is always time to quit smoking, and I'll have some resources at the end that could help you with that if you currently do smoke. Diet and exercise are very simple ways to help and really lower your risk of a stroke. Eating well, following that DASH diet, and exercising regularly, even if that is regularly just walking. And then talking to your doctor about the management of some of the conditions that were on that previous slide, such as diabetes, hypertension, hyperlipidemia, and atrial fibrillation. When you have those conditions, you can't, really wish them away, but following up with your doctor, having your annual physical, making sure you're taking medications as prescribed so that those conditions are well managed and lowering your risk of causing a stroke. Let's jump right into signs and symptoms. You may have heard it in the past to act fast or be fast for a stroke, and we added the BE relatively recently as a stroke community. This B and E accounts for those more tricky or harder to identify stroke symptoms. So we'll go through each one of these categories and give a few examples. B in BeFAST is balance. There can be a sudden change in balance in somebody's gait as they're walking. And again, with anything with stroke, any of these symptoms is really that sudden onset. Somebody could be walking and all of a sudden they're leaning or shifting to the left or right, and they may not be aware of that. So if you're with someone and you notice that, it's a good indicator they might be experiencing a stroke. The E is eyes. That's a sudden loss of vision in one or both eyes. That can be just totally one side of the vision is gone. Again, somebody may not realize that that's happening, and they could be looking at something and only seeing one half and not understanding that they're only seeing one half. Face, this is where we get into those very common signs and symptoms that we're all used to hearing about or seeing. That face is that one side is drooping. If you ask somebody to smile, it's drooping off to one side. They look uneven, they can't raise their eyebrows the same or squeeze their eyes tight the same way. The A is for arms. Ask somebody to raise their both arms, and is one drifting down, or are they unable to raise it in the first place? This is not exclusive to arms either. That can be legs. A stroke could affect somebody's only arms or only their legs. So it's just really seeing, is somebody's strength different on one side or the other, or are they totally neglecting one side of the body or the other, that they're not even aware they have a right arm at that time. The S is for speech. This is asking somebody to repeat phrases. Is their speech different? Is it slurring? Or are they unable to really communicate at all? That aphasia, where they can't get their words out and they're trying, but words are not coming. Aphasia can also be receptive, that you're talking to somebody and giving them commands and they're not following them at all, or following them inappropriately or in just a different way that's unusual. Also great indicators of a stroke. Speech is a big one. If you are with somebody who's in the hospital in the emergency room with stroke-like symptoms, sometimes somebody's speech is slurred and a little strange, but we may not know that as healthcare providers because we don't know that patient. And that's a great thing for a family member or a friend to say, this is new and this is different. Because again, in a stroke, that patient may not be aware that they sound different or they sound unusual. And the T is for time. Time is hugely important. We have named this presentation, Save Time, Save Brain. We want to know the exact time these symptoms started, because for every minute that a stroke is going untreated, nearly 2 million brain cells are at risk of dying. So we're trying to really save those brain cells, and we're fighting against the clock. So once those symptoms start, we want to know that clock time so we know where we're at in that process. That leads us to that emergency response time. Call 911 as soon as possible. Whether it is yourself or somebody you are with that may be having a stroke, call 911. Again, time is brain. Save time, save brain. We want that patient to get treatment as soon as possible so we can save as much of their brain tissue as possible. And again, noting that time that symptoms started, the faster we can treat somebody, the better outcome they will have. And with a stroke, it could be a matter of life or death. We never know. And absolutely, it can be a difference between lifelong disability or somebody going back to their baseline level of functioning from before they had a stroke. We often get asked, do you really have to call 911? Can't I just have whoever I'm with drive me to the hospital? And really, we want that 911 call because, again, it's that faster treatment saves lives and reduces disability. We want somebody to be in as soon as possible. I've been asked before as well, like, well, I was with somebody and they seemed to have neuro symptoms. They just wanted to wait it out, or they didn't want to go to the hospital. And, that's understandable. Who wants to go to the hospital? But really, with a stroke, this is one of those situations where you want to ask for forgiveness later instead of asking permission. If you're with someone and you think they're having a stroke, again, they may not be aware. Strokes in general are not painful. That hemorrhagic bleed stroke maybe that can cause a very severe headache, but our ischemic strokes, generally not painful. People may not realize they're exhibiting these symptoms. They might not know that all of a sudden they're not moving their right side, or that their face is suddenly different, or their speech is different. And so there's been many patients who have a stroke and somebody says, hey, I think you need help. And they're like, no, I'm fine. But we want to make sure that gets treated as soon as possible. It's same with stroke symptoms that are really mimicking other situations, like a migraine or a TIA is a great example that, what if I don't go because it's just temporary symptoms and it's not really a stroke? Like, I don't want to go to the hospital if it's just going to resolve itself. But again, I'll keep preaching it. Time is brain, and we want to make sure if it is a stroke that we're treating that quickly, because you don't know until we go through imaging. We don't know until there's a CT scan done and we get to look and see, is a stroke occurring? Do we need to do an MRI and do further investigation? My principle is if it walks like a duck and quacks like a duck and looks like a duck, it's probably a duck. And so if somebody has these stroke symptoms, we want to rule that out first and foremost. And if it's something not a stroke, we can go from there. But absolutely rule out the biggest, most severe cause first, so we can get that patient, that person back to their baseline, get them back to active and back to healthy, versus waiting and having regrets on waiting to treat that stroke. So really, unfortunately, for an emergency response, there's nothing you can do at home for a stroke. It's not like being able to do CPR or doing some sort of first aid in the meantime. We need that patient in a hospital as soon as possible to go through imaging, and if they need medication treatment or surgical treatment, to get that figured out as soon as possible. There used to be a standard to give somebody an aspirin, because if there's a blood clot, let's thin the blood clot, of course. And that, again, we do not want, if you're with somebody and you think they might be having a stroke, don't give them anything. This is for a couple of reasons, but the biggest one being a stroke can prevent somebody from being able to swallow like normal. It can change, they can be weak in that area, they might not have as much control, and we would hate to give them anything that they'll choke on and cause another problem. So again, we just want, call 911, get that patient to the hospital as soon as possible, and we'll go from there. That's the best thing you can do if you are with somebody or you yourself think you might be having a stroke. Call 911 and get help as soon as possible. Definitely don't wait it out. These are a few resources that you have access to at any point. They're great to read up on, whether you yourself feel you might be at risk for a stroke, or maybe you care for somebody that could possibly be in this risk category. These are great online resources to read at your leisure. We have Samaritan Stroke Services. We have a stroke aspect on our website. You can go to samhealth.org at any time and just read up a little bit more on stroke. American Stroke Association and the American Heart Association are both great resources. You can read new and upcoming articles about at-home care after having a stroke, more ways to prevent stuff, what health screening you should go through regularly to make sure you're not at a higher risk for a stroke, and National Stroke Association as well. I also put up there for you the Oregon Quit line. Again, if you smoke, there is no time like the present to quit. And there are plenty of resources out there to help, but this is a great one that you can call and get resources in English and in Spanish to help you quit smoking. And that is really the end of my presentation. I'd be more than happy to hear questions or comments from all of you.
Hey, this is Sarah. I was just going to say that we do have one question, and that is, are the symptoms the same for a man and a woman?
Yes, really there is no difference between age, race, or gender. The symptoms are dependent on where in the brain that stroke is occurring. So it does not matter who you are, where you come from, it matters where the clot in the brain is that's really having those symptoms present. And that's a phenomenal question because we do hear differences in a heart attack symptoms for men versus women, but a stroke does not discriminate. It will be really the same symptoms no matter who you are. It is fully dependent on where the clot is in the brain. Great question.
Okay, so I have another question. What if I wake up in the morning with stroke symptoms? Should I still call an ambulance?
Absolutely. We talk about that time frame when you can get medication intervention for a stroke. And that medication intervention is a clot buster to dissolve that clot. And that is within a small window. However, those wake-up strokes are tricky, and we still absolutely want to see that patient because in a 24-hour window, if that's a big blood clot, you're still a candidate to get that removed surgically. And at the very least, we still want to treat you, get you set up with resources, do a little bit of investigation on what could have caused that stroke. Do we need to look at, is there a problem in your heart? Is it atrial fibrillation you didn't know about, or some other conditions that may have led to that? And how can we help set you up for success going home? So whether that's connecting you with rehab services, or just getting that medication management solved, we still want to see you. So absolutely call 911, get to the hospital, even if you're waking up with those symptoms. Great question.
Okay, there's another question. Can numerous TIAs cause the same impact to the brain over time as a major stroke?
That is a great question. And really, because it's not a true clot, it's not going to cause the same damage to the brain, if that makes sense. And Sarah, feel free to jump in with this one. But it's not the same mechanism as a true stroke that's causing that brain tissue, brain cell death.
It's a good point. And I agree, that is a very good question. So can numerous TIAs cause the same impact to the brain over time as a major stroke? So TIAs, the true definition is that when, the real component to identifying if you've had a stroke or if it's a TIA is because we'll a lot of times see that we'll do an MRI, and that MRI will show us the brain tissue and if there's been any sort of death of the brain tissue. And if there has, then that's where we diagnose the stroke. And if there hasn't, then that's where we typically clinically have to say, or clinically say that this has been a TIA. So a TIA means that there's been no brain tissue damage. So TIA is not a stroke. And so numerous of those, no, that does not cause any damage, and it's not the same as a major stroke. But it is definitely a warning symptom that we do take seriously and try to figure out the best medications for you with following up with your PCP. I do have another question. What kind of stroke treatment can be provided in an ambulance?
In an ambulance, again, that ambulance ride is getting you to the hospital as quickly as possible. And our EMS here locally, they're phenomenal, and they are assessing you all the way. They will not give that medication treatment en route. And that is because for us to determine if it's a true stroke, we need to do that imaging first and foremost. We need to go to CT scan. So within the ambulance, they are not going to medically intervene with medication for that. If there are other things going on as well as the stroke, like somebody's extremely dehydrated, they need some fluids, or they're in another medical emergency alongside that stroke, then that is where our paramedics are going to go in and do their job and absolutely get that patient to a stable position where we can also treat for stroke. But if it's simply stroke symptoms, we think we need to treat this stroke, they're just getting you to the hospital as fast as possible, which is our goal. So we can identify that stroke and then treat it within our emergency room. Well, that's a great question.
Thank you. All right, we have a few other questions. Where are the surgical hospitals for stroke patients?
So the comprehensive stroke centers, I do believe, and Sarah can correct me if I'm wrong, our nearest are Portland, we have Medford and Bend as well. This is actually a huge conversation right now in the stroke world as well, because we talk about, hey, what if this patient does have a really big clot, a large vessel occlusion, and they need surgery? And our biggest thing is always get to the hospital as soon as possible, even if it's a critical access hospital that you have to be transferred from, just because we want to get that fast treatment with medication first, get that screening done, get that imaging done before we send you to another facility. The last couple of years, of course, this is no surprise, hospital beds are a big issue. So we want to make sure if we can treat you locally here, we want to do that first and foremost, and then identify that need for surgery if there is that need. And within our hospitals, within communication from hospital to hospital and doctor to doctor, we get that patient set up with a bed and a surgeon at another site.
Okay, so next question. So if we live 30 minutes away from the Newport Hospital, we'd go there first in an ambulance and then be sent to Albany or Corvallis?
Yes. Again, that is the most likely and best case scenario, that we are able to take you at Albany and Corvallis, because we want to keep you within Samaritan, just for ease of everybody, best on the patient, best on the staff. And again, it would depend on what the imaging says, because we could have those true stroke symptoms. Maybe for whatever reason we can't do a medication treatment, but we can, hey, still have you treated at that hospital and keep you local. Our goal is always keep somebody as close to home as they can be. And if you need to transfer, then yes, we would love to transfer you to Corvallis at Good Sam or Albany General here in Albany. So you're still within Samaritan. And of course, if bed availability was a problem, we get you to the best treatment and the nearest bed we possibly can. But always, you'll be taking, call 911, they will take you to the nearest hospital to you, which would then, in this case, be Newport. Newport will do that screening. If you are a candidate for a medication intervention, then they would give that there and then transfer you. A great question.
Okay, so if I have a stroke that affects balance, how long until recovery?
That's a great question. With any recovery for a stroke, there is no set standard of how long it will take you to recover. And again, it depends on if we're able to give medication or not. It depends on so many things. The brain is incredible, but also very fragile, and it takes a while to heal. Recovery from a stroke is not a step-by-step process. You don't have, really bad this day, the day you had your stroke, and a little bit better tomorrow, and a little bit better, and so on until you're back to normal. Some days are great and some days aren't. You may have a couple days in a row that you feel awesome and you're back to normal, and then a few that you're feeling a little bit more weak and having some balance come back. Again, the brain just takes a long time to heal, and no two patients are the same. It's just an ongoing process, so there's no clear-cut answer on how long it will take.
Wonderful. All right, so since we still have time, I'm going to keep going. Thank you for all the questions, by the way. What options are there instead of clot busters when a patient is on blood thinners?
And this is another tricky one. A lot of stroke care kind of puts you between a rock and a hard place. If somebody is on blood thinners, it doesn't automatically exclude you from a thrombolytic medication. It depends on, did that patient take that medication today already? What kind of blood thinner are they on? And if it's warfarin or Coumadin, we have to check labs first and see if you're in a therapeutic range for your INR. Is your warfarin working? Because sometimes that's the reason. Like, you're not in your therapeutic range, and that's why you had a stroke. So it is dependent on a couple different factors. If due to being on blood thinners, it rules you out with medication. Again, if it's a large vessel occlusion, that big clot, it does not rule you out of a surgical intervention. If it isn't a large vessel occlusion, then we really are limited in what we can do besides doing rehab therapy for those stroke symptoms and hopefully reaching a back to normal recovery. But that, of course, does take a bit longer when we are not able to do a clot busting medication. But great question.
Okay, and then what kind of medications are prescribed to prevent future strokes?
Prevent future strokes, great question. Once a patient leaves the hospital, or whether they had a TIA or a true stroke, they are going to go home on an anticoagulant and an antiplatelet medication. Those are your two prime medications that you will be prescribed at discharge from the hospital. Or if you're at a high risk for a stroke, regardless, and you've just gone to your routine yearly physical, your practitioner or your physician may prescribe you an anticoagulant and an antiplatelet medication for you to take daily to prevent stroke.
Thank you. And just to kind of add some clarification to that, you'll be prescribed an anticoagulant if you have an irregular heart rate, most likely. But a lot of times you'll be sent home with like an aspirin or maybe a Plavix, which is what we call kind of our antiplatelet, antithrombotic. So anticoagulant wouldn't be on everybody, but if you do have an irregular heart rate, which is a high risk, which Jodie has talked about for AFib, then you definitely will be probably prescribed an anticoagulant.
Thank you, Sarah.
Okay, so there was one other question. One second. Oh.
And while Sarah's looking, I'll throw this in because it just came to mind. We've also heard that, do I really have to take an ambulance? They're expensive. And that's really a great question. And again, yes, an ambulance could potentially be expensive, but a stroke could mean life or death, and we definitely don't want financial questions or concerns to get in the way of somebody being treated in a way that could really save their life or reduce that long-term disability. So we really want to treat that stroke in the immediate phase. And yes, other concerns can arise from that. And that's something that's great to talk with our resources here at the hospital about. But we want immediate care on that stroke, and we don't want other things to kind of cloud that, and definitely put the patient's care first. Okay,
what are some symptoms of a head bleed?
A head bleed. It's a great question. So the main difference in a symptom that is a head bleed, a hemorrhagic stroke versus an ischemic is that worst headache I've ever had in my life. That is really an indicator more of that brain bleed. Otherwise, you're going to have very similar symptoms or can have very similar symptoms to an ischemic stroke where it's affecting that brain tissue in the brain. So it's not causing that brain cell, brain tissue death because of a blockage, but it is a bleed. And that blood is negatively affecting those brain cells. So it can cause those same similar symptoms. So you may have that weakness on one side, aphasia, all these different symptoms that we see in a true stroke. The main difference is that I have the worst headache I've ever had in my whole life. And that's a great question.
What blood tests are used to determine if a person is likely to have a stroke?
That's a good one. So that's going to be looking at what are your risk factors. So diabetes puts you at a high risk for a stroke. Let's look at your A1C during that annual physical regular blood draws. Let's look at your INR. Like, do you have a clotting problem in your blood is what we're looking at. Do you need to be on a blood thinner? Those are the other labs we're really looking at. Lab-wise, it can be hard to say, wow, based on their lab values, they're going to have a stroke. But really, your lab values are giving us a good indication of some of those other conditions that are then risk factors for a stroke. So we're screening for diabetes, we're screening for atrial fibrillation, we're screening for your cholesterol levels, hyperlipidemia. We're looking at all of those things because those conditions are then risk factors for a stroke. But there's no one lab value that says, yes, you are going to have a stroke in your future, or no, you are not. But a great question.
That's pretty much all the questions.
Wonderful. I have one more thing that I'll add on there because nobody asked it, but it's a common one too. People who have migraines chronically, they end up getting complex migraines, often have asked, how do I know if it's a migraine or not? And again, it's one of those hard ones of if you get migraines chronically and you know what your migraine symptoms generally are, then you know what your migraine symptoms are. But again, if it is mimicking those stroke symptoms, you want to rule that out first and foremost. Definitely, you can never be too cautious. You can never be too safe when it comes with a stroke. And migraines are a huge mimic, but you don't want that, oh, I bet it's a migraine, it'll go away kind of thing to then prevent you from getting care. So the standard is always, our answer is generally the same. Come to the hospital, call 911 if you are having stroke symptoms. But thank you for all of your questions. They have all been phenomenal. Love it when people get to participate with us and engage in this conversation about stroke prevention and stroke care.
Jodie, did you tell them about the questionnaire to test their knowledge?
Yes, absolutely. Thank you, Erin. We do have a very brief survey that Dan or Sarah will be dropping in the Q&A box as an announcement. This is just to gauge if we taught you or not. Our own feedback. There are no right answers, but please use that survey for us, and we would really appreciate that.
So these are some of our other upcoming Healthy Minds, Healthy Bodies and virtual seminars. We've also got some of our Foundation Med Talks coming up, and you can register for those at samhealth.org/behealthy. And we want to thank you again for joining us today. Your feedback is valued. And if you would, please take a moment to complete the brief survey, which is now available in the Q&A box. The first one is to test your knowledge. The second one, so the first one from Dan is to test your knowledge. The second one from me is going to be just to tell us how we did today with our virtual meeting, and it can help us improve future meetings. Please watch for a follow-up email that will include the link to the recording, and it will also be posted on our website. Thanks, and have a great day.